speaker is Dr. David Feldman. He's a section chief of advanced myocardial therapies and director of heart transplant and mechanical circulatory support at Robert Wood Johnson, Beth Israel Hospital and Rutgers University. He will be talking to us on PV loops and shock management, bedside.
So it's worth mentioning here the title here, which is PV loops and more in shock management, benchtop to bedside, science you can use today. And I think that the conceptual concept behind why this is relevant is more relevant than the actual topic itself. So disclosures here, as I have no disclosures as of today regarding this subject. I want to thank the organizers, and I will beg the indulgence of the organizers to give me a couple of minutes to get this done, because it's actually more words in the title than I have minutes to actually talk about this subject, PV loops. And the conundrum of the day is then actually how to get that done. And really, there are only three things you can actually learn possibly about PV loops in 8 minutes. You either don't care, you actually already know everything I'm going to say, or I'm going to give you a primer of you need to go back because 8 minutes, not 80 minutes, is actually going to accomplish the goal of learning something about PV loops and cardiogenic shock. So then I have to have a very fine lens. So Mike Mooney said to me last night, can you talk some about preload? Because everybody always talks about afterload in cardiogenic shock. So, this is what we're looking at. This is the physiology of a pernicious cascade that we see where, in fact, patients are dying, and you don't really know exactly when you're dying, because the comment has been made several times here today that the actual data or the facts doesn't necessarily match the phenotype, and so we're lost at a position about where exactly we should be doing things. So basic science at 3:30 in the morning, you got to be kidding, right? Okay, because that's what we're really talking about here. So you got large clinical trials in the middle of the night. You got previous experience, my wisdom, in my case, none. You have your ethical compass, which is what would you do if this was your mama? And then there's just you, the patient, and basic science in the middle of the night. So that basic science, even though it seems like it's irrelevant now today for these talks, is probably more relevant than your large clinical trials, your observational studies, all of those things, because ultimately it's just you and a patient and hopefully a few people around you to help you out. So how is one patient going to be better tomorrow? That's really the question, right? So oxygen transport, there was a concept here about the ability to actually get blood out or the ability to perfusion, but let's do a deeper dive, because this is molecular biology, right? It's really not even about perfusion. It's about what is the definition of heart failure, and if you get down to the basics of it, it's the metabolic need of what we blame otherwise the heart, but it's really the whole systemic body, the ability to feed the cells of the entire body. And when you're not doing that, that's heart failure. So determinants of oxygen delivery, everybody knows stroke volume times heart rate is cardiac output, okay? But into that goes that preload, that afterload, the contractility. But on the bottom there, you have things like hemoglobin. How many boxcars do you have to carry that oxygen, which is a surrogate of your metabolism? How quickly does it dissolve? How quickly can you remove nutrients and actually get it from the blood into the cells? Well, you can't have this talk without having a Frank Starling curve, and the only relevance here is that it's a segue for me to say that intracardiac filling pressures are particularly germane. There was a concept as well that, in fact, we want to hang on a number, and a number is never going to be anything but part of a Rubik's Cube. So this morning we were talking about, what blood pressure is relevant. Well, I would have said, it's always a constellation of things, and maybe you need to be looking at power calculation. Your blood pressure can be a map of 100, but if your cardiac output is 0.9, maybe that's not enough. I use this cartoon because I'm actually making fun of myself, and this is how we kind of think about it. You think about afterload, and it's like the aorta, and you got, some kind of tourniquet around it, and then you're going to release it, and now the heart's better. And when you're talking about preload, for the left ventricle, you're not really talking about all the stuff that you're shoving in the IVC or the SVC. You're actually talking about that other small organ called the lungs, which is the capacitor that gets you to the left side of the heart. So perhaps one of the reasons that, as soft pitches from the panel this morning, that in fact you have greater death with biventricular or undescribed shock is the multitude of mechanisms for how that, is what's actually going on. Well, this is the magic slide, right? And this is the one that in fact that our fellows all need to know for the boards, and we do our best to actually expunge this from our database in our brain as soon as we walk out from that test, with the exception of Dr. Berghoff, of course. By the way, he is available to come to your home. It's $1,000 an hour, Dan? Okay, all right. So I'm going to keep moving on here. Please don't cut me off. This is what, I learned that from Dr. Katz this morning. This is what diastolic and systolic heart failure look like. What you actually see with that heart failure is that in fact you see an increase in pressure, you see a decrease in volume. But as granular as this is not even specific enough. This is what preload looks like. And when you're talking about, for instance, atrial contractility, you're talking about left atrial contractility. How many times does anybody actually ever talk about left atrial contractility in cardiogenic shock? That matters here. Heart rate matters. If you don't have lusitropy and you're not actually filling the heart, preload is irrelevant if you actually have that sine curve that we talk about where you have the square root. Okay, this shows that in fact failing hearts don't fill as well. And this shows that if you look at I guess it's blue on the bottom there, Mike asked me to mention this. One of the things that we found when we put together the mechanical support guidelines is the guidelines by definition are a consensus, and so that means you have expert opinions. And you can see people that get pounded with volume. I want you to look at that right atrial pressure on the bottom, and in a failing heart, as opposed to an exercised heart, like if we took some viral specimen like Marwin, and you look at this, you can see that if you have a CVP greater than 12, you get absolutely no benefit from this. So when somebody says to me, because I like a swan, I don't really have equipoise about that, what would I do? How much volume, doctor, should we give before we know they're adequately volume resuscitated? Should I give a liter, 2 liters? Well, the answer is I want a CVP between 10 and 12, because anything more than that, it ain't gonna help. This just shows the afterload because in fact you can't talk about preload with that afterload. And this shows, in fact, the one slide I was asked to show, which is that, what happens with a PV loop with temporary mechanical support and heart failure. The upper one is intra-aortic balloon pump, the lower one is Impella. For the sake of time, I'm gonna keep moving on. You're more than welcome to have my slides. Okay, evidence, benchtop to bedside, shock management. Myocytes are unhappy in cardiogenic shock, you need to fix them. Class 1 recommendation, level of evidence A. Works at 3:30 in the morning. Hearts are not producing enough cardiac output to stop cellular death in extreme cardiogenic shock, you need to now fix it, not next week. Class 1 recommendation, level of evidence A. We are doing better than the guidelines here, you see? Basic science does matter at 3:30 in the morning. Afterload, preload, pressure volume, and utilization of your brain, not the guidelines or trials, may save your patient in the middle of the night. Class 1 recommendation, level of evidence A. There is still no surrogate to having the right person in the room. It's not about a body. The hardest commodity we have in all of these programs to develop adequate resources is the right people, not the right number of bodies. Final thoughts. You can build a perfect machine with MCS, but you can't, it doesn't address the lesion. It's the human heart that's failing. Mechanical support is nothing more than a crutch for a broken leg. You must fix the heart. What is the plan tomorrow? And one of the things I haven't heard in a day and a half now is, where is this patient a month from now and what is their quality of life? There are worse outcomes than just dying. Okay, I did that in 8 minutes.
So tell me, you clearly stated that all this information is so useful in cardiogenic shock, which all of us agree. Yet in the previous talk, we were debating that we don't want to have a device which will give us more information. Because like Yuri said, 40% of the time, physicians did not predict rightly the hemodynamics of a patient, and 70% of the time they changed the outcome. So why would we need to do a trial? It's like saying I have a car, I'm driving in the fog, I have two lights, I can't see very well, 50% of the road I can see. Would you do a trial to show that if there's a light which gives a little better visualization, should we do a randomized trial?
Dr. Carr, I think that's a good question. So I look at this a little differently. So I think what we actually said before was, in fact, we can't trust essentially what we see, that the granularity related to a SWAN is helpful, that the ability to assess the patient at bedside without that was not nearly as prognostic, and that in fact we all changed our minds. All I'm saying is after you get those SWAN numbers, or whatever it is, or the echo, or whatever it is that you want to use, to actually extricate your brain from the ability to actually integrate that information is really problematic. And what we see frequently is that in fact somebody will hang on to a lingering number or a concept as opposed to looking at a constellation of things. It is rarely a time in the world, no matter what we're talking about, whether it's medicine or anything else, that everything comes right into line. And so I think that ability to integrate and make the best choice is all going to be between our ears and not in a Swan-Ganz catheter at the end of the day. And I think that that's probably only garnered with time of around the block.
Because I think only thing we need to debate is whether the same set of information can be obtained through like echo and someone else suggested non-invasive ways than getting through the SWAN. But what we shouldn't be debating is should we get that information or not. How we get it is something is debatable and technology will guide us.
I'll take as much information as I can get.
Exactly.
My dad always used to say, I'd rather have it than not want it than want it and not have it.
Yes, absolutely. Go ahead.
So great talk, David. It got me thinking about in cardiogenic shock. We know that, of course, the periphery is extremely important, but we know also, I think, that the heart of the matter is the myocardial contractility in cardiogenic shock. I mean, that is to some extent the origin of the problem, should be. And when we look at the measures we get from the SWAN, when we get the metabolic measures, lactate, liver function test, renal function, urine output, whatever, we're all looking at the consequences of myocardial contractility, but we don't have good information about the state of the contractility of the heart. And that's where PV loops, of course, could be beneficial if we could do them at 330 amp. Is there a good way to address the myocardial contractility from the measures we have from the SWAN, etc., cardiac power calculations? Is there anything we can use to try and get to that part of the cardiogenic shock?
Well, Finn, that's an awesome question as well, and I wish I had a clear-cut answer for that. I guess what I would say is that, in fact, to the extent that if you could just make it, for me, just simplify everything, because I have to. If we were to say there's the rest of the body or the periphery and the vasculature, and then there was just the heart, there are times where, in fact, you can lean on one versus more than the other. Dr. Owen this morning actually presented a case where the SVR was 15,000. Now I'm exaggerating, of course, but the point was that in fact, addressing your needs directly at the vascular, perhaps the heart was still stiff and the myocardium and the ability for it to have contractility was impaired, but by actually releasing that rubber band on the aorta in that cartoon would make a significant difference. Unfortunately, the SVR typically is not 15,000, and it's typically not 500 where you go, oh, this is sepsis and let's start 2 antibiotics. And the in-between may give you some feeling for how much of this is intrinsic cardiac disease versus this is systemic issues. Now, the other thing you can do is by looking at the echo, you can tell something about this heart by the time frame. Near alluded to this, and we talked about the fact that, signaling changes with time, and the heart keeps trying to accommodate for a pathological cascade that's going down a rabbit hole. So, when you see, David Barron showed yesterday, a right ventricle that's bagged out, that right ventricle didn't get bagged out in like 15 minutes. It took a while to get there. So you can also, perhaps using content between your ears, that based on the history, I know that's a lost concept as well as the history and the physical, the history may give you some insight into the relevance of your hemodynamics, that actual background laid on top of immediate data in front of you may make the data actually more relevant.
Thank you, Dr.
Let me make a quick comment, to kind of bring a few of these things together. I think, that was a great talk. One of the best comment I saw was your third bullet point on your second to last slide about integration of everything. And the issue we're dealing with is that we have tools that work, but we have a history of time where people used them a lot before, now they're not used, now we're debating, should we use all these things? No one will debate the fact that you win with data. Data is key. Data is the new oil. Everyone uses data. The more information we have. The question is, what's the best way to be able to present all this data in an integrated fashion that we can use in today's situation? I made the point about coronary perfusion. Nir made the point about the whole body. So you have to think about context. What's the patient context? We need an evaluative, easy way for people to deal with that. Does the patient have cerebrovascular disease versus not? Do we need a lot of pressure or not? Is it only the heart? So you get the context thing. Then, maybe a better way, like a heads-up display, for us to be able to present this data, because in the days gone by, it was the resident and the fellow, two people making that decision, and then the next morning it was a great choice or it was a bad choice. In today's world, where people are maybe more concerned, worried about how to handle all this, we need a sort of integrated data way that maybe in a team way, we are presenting this information, it's online, it's being evaluated, and that type of system put in where you have a sort of an AI or a smart system to evaluate this, with humans, of course, would be a better way as we move forward to handle all this stuff, understanding the body, the heart, and all this in a simple way that we're not second guessing, did I make the right choice? It could be kind of a smarter system.
So if I can amplify what Dr. Konstam and what Dr. Carr actually said is that, in molecular biology, if you have 1 million data points, then the ability to actually come up with a relevant solution is probably zip. And the ability to so too much data can be a problem.
Sure.
But the ability to take the most amount of data that you can get that's actually accurate, real data, because the only thing worse than no data is bad data, right? Is the ability to take that data and then integrate it. And that's what I'm proposing is the benefit of basic science, that we, that all of those years that we do before we get to the bedside really do matter.
I think it's actually, I'm just going to support your point here. Not everything we do actually have to be clinical. Sometimes we need to understand what we do. And maybe I have a luxury because Dan and I have a long, long relationship. And I think if I would ask how many people here really did pressure volume loop, I can divide it into two. In the cath lab, probably there will be 1 or 2 people that will raise their hand. And how many of you really actually play with Harvey, not only in Teach yesterday, really on a daily basis, it will be the same. But what actually pressure volume loop give us is understanding. You're actually learning, and it's okay. We, a clinician, academician, sometimes we actually, there is a toolbox that we have that explains us why we act as we act. And I actually feel this question specifically, pressure volume loop, is it something that can come to the bedside? Pressure volume loop is in the bedside if you learn it. You're not going to use the pressure loops themselves.
Sure.
You are going to understand the essence of hemodynamic by understanding pressure volume loop.
Thank you. David.
Thank you.
One comment would just be that I think we need to look at this in many ways like religion.
Think about it,
Everybody has their own particular religion, their own particular church, which has their particular thing, and it works for them. And so if you, for example, find that an ECOS or some device is how you do it best, then you should continue to do that if you take good care of patients. On the other hand, I prefer Swan. I think it's cheaper, but I respect the fact that somebody else may say, no, I'm an expert in echo and pocus and hocus, and that works for me. As long as it works for them and their patients, that's great, because I can't take my perspective and insist that everybody else uses the same, as long as the output is good. In other words, religion prevents you from doing bad things and teaching your children good values, that's great. Doesn't matter what particular flavor it is. I don't think you'll ever convince everybody that a Swan or an ECOS or an Echo is the right way, but that everybody should say, do the best for the patient, and whatever you have, if you have a winning horse, continue to do it and teach your team the same.
Thank you. We're going over time. We'll get the last comment here from the audience. Someone behind you? Yes.
Yes,
I can't see it.
I mean, I agree with a lot of what was said. I worry that we're making things too complicated for most people. I just wonder if we need to kind of boil things down to a sort of a few things that we all agree on. So in some ways, I disagree with David. I think that there are a few things that we can all agree on. You know, if you guys could look at the Abrahamic religions, I mean, I think that there are some things that we all agree on. And so, I mean, I think that you know, if we start getting all this extra information and all this other stuff, boy, it's really, I think we're asking too much of most people in the community to integrate all that stuff. And I agree with Nir that we sort of do a virtual PV loop when we see the patients, and maybe we should be teaching people to sort of think about that and use a few key pieces of information to make good decisions rather than layering more and more and more stuff over top of it. You know, we can't even all agree on sort of what hemodynamics are best. And now we're talking about what echocardiographic parameters that are surrogates of those hemodynamic parameters are best, and we get further and further and further away from the sort of truth, so to speak.
You know, Jeff, what you said is that I kind of use the analogy in my brain that this is like sports. You know, the ability to swing a baseball bat, the mechanics of that is something you have to have down way before you ever step up to the plate. And it has to be something that is, you know, like muscle memory in your brain. That you actually apply this to make it, it's got to be easy at 3:30 in the morning, otherwise it's not going to happen. Nobody's pulling out a PV loop, and despite my regard for Dan and his program, I don't know if I've ever seen anybody pull out the Harvey program, maybe Columbia. I've never seen anybody pull out the Harvey program at 3:30 in the morning.
Well, it is used on rounds, teaching rounds in a lot of places.
I totally believe that. That's after being caffeinated at 7:30.
Not at 3:30. I would just say that I think in 5 years from now, with the advances in imaging, we probably will have bedside PV loops. There's a lot of advances being made in imaging and integration of hemodynamics and imaging and other stuff going on in computational field that will actually make this come closer to the bedside.
But simple system integration of that, I'm not arguing for a million data points. I'm just saying if you have an easy way to present it, then it's easy to interpret. And I think we can also do things to help in that domain for everybody, which would be make it more universal.
Yeah. I think we're way, way, way behind.
Thank you, Dr.
Thank you, David.